Reza, thank you for a lot of things, including staying on time. Okay. Blair, that doesn't mean you have more time to talk. Diagnosis and treatment of LPR is largely ineffective. What are we missing? Blair, you will give us the answers.
I'll try, Joel.
Good, thank you.
Hi. So I'm going to talk about some of the challenges that we encounter in this field. These are my disclosures. So what I'm going to do is I'm going to define the current state of diagnosis and treatment. I'm going to talk about how we need to unhook or disconnect from the traditional GERD testing paradigm in the context of this problem. I'm going to talk about why it's a vexing problem. And then I'm going to talk about why the interdisciplinary team is the most important component of how we're going to improve in the care of these patients. So let's start with nomenclature. Just as Reza mentioned, the term LPR adds to the confusion, particularly the R part, because it's an a priori designation of a set of symptoms that often aren't reflux related. And it also biases the provider to start thinking that, oh, this has got to be reflux. So if an ENT sends you a patient, all of a sudden you're like, oh, it's got to be LPR because they said it is. So it's a very important thing. So what we propose and what we're proposing in our clinic is to call it chronic laryngopharyngeal disorder, and to start with and break it into three, which is GERD-associated CLD, isolated CLD, and mixed CLD. Isolated would be something like amyloidosis affecting the subglottic region and changing the voice, and thought to be LPR. So let's part from the GERD-based school of thought. The diagnosis and treatment of GERD is more straightforward. Esophagus is exposed to gastric contents, and that results in symptoms. One cause, one effect. Measurable, we can measure it with pH testing, and we can correlate it. So when you have acid in the end of your esophagus, you push the button, we try and correlate it, and that helps us direct our therapy. So we call that one compartment. That is the GE junction. The diagnosis of LPR type symptoms can be extremely difficult. You have multiple etiologies that can cause it. They can either act singularly or coexist and then potentiate each other. So, for example, if you cough, what happens when you cough? You reflux. And what happens when you reflux? You cough, right? So these things get into a vicious circle, and until you break the cycle of one of those things, you're not going to go anywhere. You're just going to hold in this pattern. And there's really little to no symptom correlation with testing modalities. For example, you only need 3 exposures to your hypopharynx per week to cause chronic symptoms. And you have the potential for multiple compartments: the lungs, the throat, the GE junction. So these are the potential causes of LPR type symptoms. And you can have allergies. I mean, we saw patients like this last week. They have seasonal allergies. They have chronic systemic illness, such as a mixed connective tissue disorder. They're smokers, and they have GERD all at once. So, and then, as you know, with GERD, I'm simplifying here, but typical GERD symptoms is acid on esophagus. And these are the symptoms and signs of LPR, and they're, when it comes to this field, words like plethora and myriad are used a lot because there's so many things that can impact it. And as you saw from Reza's presentation, by the way, he's the world expert in that area. And so it was a real honor to have him here and to have him talk to us and share his insights, because he's really the one that has defined all of those reflexes. Laryngoscopic signs of LPR are not specific, and a lot of the ENT physicians don't know what to do with a cough patient. So they put the scope down, and they see that they have some changes, and they put them on PPIs, and then they hope it gets better. And it's not a diss on them, it's not disrespecting them, it's a very difficult area, and this is a truly multidisciplinary problem that requires insight from each discipline to understand what the other discipline does, so that you can have an additive insight into what's going on. But these are some of the things we see. This is an LPR patient, and you can see that below the true chords there's this outpouching. Okay, that's called pseudosulcus sign, and that's a sign of subglottic edema related to reflux. Okay, and you see the erythema and you see the edema. This is a patient with granulation tissue on the right, or on the right vocal fold, as well as you see bile-stained gastric fluid in the piriform recess. So what are the primary problems that we encounter? The first is there's no gold standard for diagnosis. You know, what Lena does in her practice and what I do in my practice might be completely different, albeit equally well-intentioned. Non-specific and multiple types of symptoms. So there's a whole thing, as I just alluded to in the first part. There's multiple etiologies. LPR can exist in the absence of positive conventional pH testing, and I think we get too fixated on that. There's no agreed upon standard for impedance. So if you look at there was just a paper published that looked at how impedance is used, and there is a table that is literally, you know, this big that tells all the different protocols that are used. And to compound matters, the impedance technology uses multiple different catheter types, the configurations of the ring sets that are on that impedance catheter. The incidence and prevalence of this disease is unknown, secondary to the lack of a gold standard. And that point before is, you know, you can have cough related to reflux, and you can have reflux related to cough. That's the point I wanted to drive home. And again, as I mentioned, there's little time correlation between LPR symptoms and laryngeal exposures. Our symptom assessment instruments aren't entirely adequate, okay? And there's a whole plethora of them. Another problem is the PPI trial. So there's 3 really well-done studies and 3 meta-analyses that show that there's no benefit versus placebo in patients with LPR-type symptoms. Despite this, it remains the recommended mainstay. If you look at these little algorithms that everyone has, PPI, start PPIs. And the reason for that is sometimes it is effective, but you have no way of predicting who that person would be. And this often creates confusion secondary to placebo effect or inadequate assessment and treatment of non-reflux-related factors. And then there's the trips and pepsin thing, which I'm not going to cover in this talk, but just suffice it to say that there's a lot of us that are working on developing an assay that you can, either through spit or doing a hypopharyngeal biopsy, that will help us do this. And we, in our group, we think it's probably going to be a ratio of CEP70 and pepsin, as opposed to, and pepsin. So if you have a ratio, CEP70 is supposed to be protective. Pepsin injures the tissue, and if you look at that ratio, we've seen preliminarily in our lab that might be a good diagnostic tool. This is why dual probe pH testing doesn't work, and this is a serial multiple level pH probe, and you can see that as you move more proximally in the esophagus, as it mixes with saliva, the pH goes down, and that's why 40% of LPR events would be missed with dual probe pH, secondary to a false negative. So the current algorithm is patients with LPR symptoms present, they're put on an empiric trial, and they're either improved, upon which they stay on PPIs and plus or minus neuromodulation, or they're unchanged, in which case you need objective assessment. But the problems with this are nonspecific symptoms, no therapeutic benefit of PPIs, and a better need for direct measurement. And this is what our patients go through. So these are the patients that we're seeing actively in our clinic. They present to their PCP with LPR symptoms. They see specialist number 1. After specialist number 1, they have exam, diagnostics, and a PPI trial. They have negative results of that testing. They have no response, and they go on to specialist 2, 3, 4. They have further exams, further procedures, no response, and then they go back. And what we see in our clinic is we see people that become housebound because every time they go out, people think they're sick. They can't go to church anymore. They can't go to a movie. They can't drive because they're coughing so hard they pass out. And this leads to relationship issues, depression, frustration, expense. So this is a really profound problem. When Mike Vasey quoted that number of, I forget how many $1 million or how many $1 billion the impact of this disease is just profound. So the relationship between GERD and LPR, less than 50% of patients with LPR have pH-positive GERD. And in GERD patients, pH-positive GERD patients, LPR symptoms are very prevalent. Excuse me. I want to differentiate two types of LPR patients. There's the easy-peasy ones. So the easy-peasy ones are those that have a huge, maybe even a paraesophageal hernia, and they have cough, and they're referred as LPR. That's a different animal than the patient with normal anatomy and isolated upright reflux. Most of these patients will come in and say, I don't have heartburn, but it's important to query that because of their PPIs, their heartburn's kept in check, and that the manifestation of their LPR is just a progression of this volume bipositional reflux. But this is the hardest of the hard patient, isolated LPR symptoms in the absence of typical GERD symptoms and normal anatomy. So this is kind of our hypothesis as to why upright reflux happens. You know that we have two components to our LES. There's multiple components, as you learned from Peter yesterday, but there's an intraesophageal component and there's an intragastric component of the LES. And we believe that over time you get thinning out of that collar sling musculature where you initially lose the intragastric portion of your LES. So what happens is when the patient's supine, the air and fluid in the stomach go up to the front wall of the stomach. And when the person stands upright, you get a nozzle effect. You know, like when you're out watering the garden, if you turn down the nozzle, it's going to go much further. This leads to aerosolization, maybe even a positive pH test. And remember, 3 exposures to the hypopharynx to cause chronic symptoms. So this is what we think is happening. Let's talk a little bit about impedance pH testing because I think this is a critical adjunct to the workup of these patients. Compared to conventional pH testing, we know that impedance testing improves sensitivity and false negative results. It enables detection of acid, non-acid, and mixed events, and aerosolized events. It enables detection of symptomatic non-acid distal events. So if you have a patient that comes in and says, I swear to God I'm having heartburn, and their pH is stone cold normal, you do this test and you see that they have symptom correlation with heartburn and non-acid events, then you can operate on that patient and they'll do very well. Symptom correlation in LPR is really not that useful. The drawbacks to impedance is there's the potential for false negative results because of the short testing period. This is a 24-hour test, and oftentimes it's 16, 18 hours. A positive test does not predict response to therapy. There's a myriad, there it is, of diagnostic criteria compounded by variable catheter configurations. So we use a certain type of catheter, which is an LPR catheter, which we designed, or helped design, about 10 years ago. And we've been using that, and we built our entire normative data around that catheter. So if you use another catheter, it throws everything off. So that's why you get isolated in your understanding of this disease. And so what we really need to do, and through this society, I'm hoping that we can do this at some point, is really develop a consortium where we can understand, let's do this on a large scale so that we can disseminate things and that our studies all mean the same thing. So that way we can understand the impact of what we're doing. Widespread and routine use guided by agreed upon pathways is limited. So in other words, there's a lot of people that just think Bravo, right? Or all they have access to is Bravo. So that's all they're going to use. So when they have an LPR patient, that patient's just probably going to get bounced around because they'll have a negative demister and they might not, you know, they might not get the care that they need, or they might not have access to that technology. And it's difficult to compare the study results, as I mentioned. So this is the catheter we use. This was the bifurcated catheter before we made it into one catheter, or it was made into one catheter. And you can see that there's 3 regions. There's the distal region, there's the proximal region, and then there's the hypopharyngeal region. And on the right, you can see an LPR event, which is acid to acid. So you see the esophageal pH at the bottom and the pharyngeal pH at the top. So the acid entry, and then you see the retrograde decrease in impedance moving proximally in those 3 regions. So this is an acid to acid LPR event. This is one just last week that Sherry, my PA, shared with me. And you can see here, this is a true liquid LPR event that is non-acid, or almost maybe mildly acidic on the distal one. So how we define LPR in full column reflux, LPR is when it reaches above the upper border of the upper esophageal sphincter, and full column reflux is when it goes just within 2 centimeters of the lower border of the upper esophageal sphincter. And I'm just going to buzz through this because I see I have 5 minutes left and there's so much more I want to say. So impedance helps you understand all reflux. Dual probe just helps you understand pH. Okay? Categories of LPR are acid to acid, non-acid to non-acid, and acid to non-acid. So what we did is we took 34 CMU, PIT, hospital employees who had never had reflux disease, had never seen a PPI. We did transnasal unsedated endoscopy in the office to confirm that they didn't have a hiatal hernia or any evidence of esophagitis. And we did this impedance testing using this probe on them. And what we found is that LPR and full column reflux are actually pretty rare. 0, so the median was 0. So 75% of the data, could you back that up for me? So 75% of the data was around 0, so it's exceedingly rare. Full column reflux, 1 event was the median, and the total number of reflux events was 22. So we took 95th percentile of that data as our cut points for abnormal. So anything greater than 1 LPR event is abnormal. Anything greater than 4 high proximal events is abnormal. And anything greater than 48 total events is abnormal. And so we took a group of patients that we had that had treatment responsive. They had 100% response with anti-reflux surgery who had LPR. And we looked at the total number of proximal events. And you can see there's a wide disparity between that and the normal population, while the total number of reflux events is normal in both groups. And all of these events occurred in the upright position. Again, you see the total number of reflux events is the same. So I just want to talk a little bit about our team. On the left is Ann DeWitt, and Ann is here with us today. She's our dietitian. On the middle right is Kimmy Fleming, who's our psychologist. On the far right is Leah Nestlerode. And then Brittany Weber is our otolaryngologist. And so we all work as a team, and we all work every Thursday together in the same place, same location, and have all of our testing in that area. And so we are actually in real time talking to each other. You don't have to have this. It's all about relationships and how you build those relationships with the people that you're going to work on with. Okay? But that's what our team is. We have real-time interactions, we have a shared purpose, and we have full in-office testing. So we say, keep calm, peel the onion. So that's what you got to do with these patients, is you got to work the differential. So this is a 29-year-old female presenting with 7 years of cough, PND, and throat clearing and chest pain. She never has had heartburn, and she has intermittent nocturnal choking, never smoker, not on an ACE inhibitor. She's seen 2 ENTs, a pulmonologist, gastroenterologist, with no improvement. Provider suggested that it may be psychosomatic. She developed anxiety, depression, marital difficulties. PPIs didn't work, and all of her testing was negative. And this is her Pria Bravo before coming to us, and what you can see is that she's an isolated upright refluxer, and these little reflux events were with coughing episodes. But the Demeesters were 3.6 and 3.7 on day 1 and 2. When you look at her SLP or an otolaryngologic evaluation, her sinus CT was negative, reflux finding score was negative, flexible endoscopic evaluation of swallowing was negative, voice assessment was negative. Nasopharyngoscopy showed a little bit of erythema and slight edema of the arytenoids, and she was negative for subglottic edema, pseudosulcus, and granuloma. On retroflexion, you see she has a Hill classification grade 2 valve with Los Angeles classification grade A esophagitis, a Prague classification of C0M1, no hiatal hernia. But you can see on her manometry, she had loss of the intra-abdominal length of her LES, and it was slightly hypotensive. And on impedance pH, you can see that she had 13 full column events and 4 LPR events, and so this is considered positive. This was acid to acid event on the right, which was, and all of these events occurred exclusively in the upright position. Her psychological assessment, she has situational depression with anxiety. We started her on an SSRI. She's undergoing weekly counseling with Kimmy, doing meditation and biofeedback. She met with Anne, and she got pre- and post-operative assessment because we were going to operate on her, placed on alginate therapy, small meal size, and a hydration regimen. And so we performed a LINX, and at 7 months follow-up, she had complete resolution of all of her symptoms except continues to throat clear. And this can be a habitual problem, and she is now working with Leah, having voice therapy to resolve this. Can you play video number 1? Okay, guys, so can you turn up the volume maybe? So what do you see here? What looks abnormal? So if you look, normal is in the far upper left in that static picture. You see there's a kind of a fullness below the true chords. So the presenting symptom was voice changes in this school teacher. She had one proximal event and a negative Demeester score. This is amyloidosis. So it was biopsied and found to be amyloidosis, and this was a new diagnosis. So she went to the Cleveland Clinic to be treated for this. Next video, please. So look at, see how that left cord is ball valving up and down, and the right cord looks funny there? Patient presents with hoarseness and cough. What does this patient do? Can anyone say? I mean, what do they do that caused this? What? Nope. This is Reinke's edema. The patient had from smoking. So the patient had microlaryngoscopy with an incision and drainage of this, and underwent voice therapy and did not need anti-reflux surgery. This patient, next video please. So this is a video stroboscopy, and I don't know if you can hear it. The patient, we're asking the patient to make sounds at different ranges. And you can see the chords elongating as they try and go higher, okay? So this patient came in with heartburn, pain, and loss of range. Can't sing at church anymore. 5 proximal events and a positive Demeester score. So this is likely overuse and reflux. So this patient, because he had heartburn and wanted to get off PPIs, underwent a LINX procedure. Next video, please.
Good, breathe. Lower pitch E. Good, breathe. Good, breathe.
So video stroboscopy enables you to see how the chords move during phonation or singing. What do you notice about this patient?
Good, breathe.
So there's a left vocal cord nodule there. Patient has cough, globus, mucus, 12 proximal events and a positive Demeester score. This patient underwent a LINX procedure. I'm going to skip through this part, although this was really good, and if you want to see it, I'll show you. This is pharyngeal. This is a patient with a CP non-relaxation, and this is pharyngeal manometry showing an achalasia type picture. This patient underwent a CP myotomy and did great, but that was a FEES test that showed non-emptying of the hypopharynx. So what I wanted to do, we just got this accepted for presentation. This was work done by Shaheen Ayazi, who's in the crowd and is I'm lucky enough to have him as my own fellow. And we've been working on a lot of projects together, but he put this together. We've done now 600 LINX, but of the 413 that we've done, 87 presented with a primary symptom. They may have had heartburn, a primary symptom of LPR. And what we did is reflux symptom index at baseline and a mean follow-up of 12 months. We looked at, we defined an RSI of greater than 13 as being abnormal, and we defined a favorable outcome as resolution of LPR symptoms, freedom from PPIs, and normalization or a 5-point improvement of RSI. And then we did a multivariate analysis to define predictors of a favorable outcome. And what we found is that after LINX, RSI at about 12 months follow-up, RSI decreased from 27 to 11, which was highly significant. 84% of this population had a favorable outcome meeting all 3 criteria, which when you really work these patients up and you really work the differential, you can achieve outcomes that are similar to Nissen fundoplication, or similar to that for a patient who presents with typical symptoms. Predictors of a favorable outcome were a higher preoperative RSI, a higher preoperative Demeester score, and a larger hiatal hernia. I was kind of disappointed to see these results because what that's telling me is that the more you are like a real typical GERD patient, the better you're going to do. So I was a little disappointed. So the pertinent negatives here is that it relates to favorable outcome. So these are negatives. There was no relationship between outcome and demographic data, preoperative high-resolution manometry, LPR events, or full column events. But keep in mind that these patients were highly curated and got operations because we really worked them up. So we may be just seeing a highly curated group of people. So in conclusion on this study is MSA is a highly effective treatment in patients with LPR dominant symptoms. Team medicine in a highly complex disease process is fundamental to success. So our mission, develop trusted relationships across disciplines and actively communicate. Avoid the refer and forget. So if you see these patients and you're going to take them on and you're going to consider operating on them, you need to be invested in them. Otherwise, it's not going to work. You're going to have bad outcomes. Gain access to impedance pH technology and use LPR configured catheter. And you have to really analyze the results of this in the context of all of your testing and the patient's clinical presentation. LPR can occur in the absence of a positive Demeester score, and 40% of proximal events would be missed with a dual probe. Be a detective and leave no stone unturned. You will begin to see patterns, and that's very true as we all in our little Thursday clinic talk. Remember the vicious circle. Chronic cough can cause proximal events and vice versa, so you need to break the cycle. So sometimes in order to start working on someone's larynx, even if it's not a primary LPR problem and they have LPR, you got to treat them so that you can now go to work on their larynx. Otherwise, you just have a vicious circle. The PPI test, just take it for what it is. Identify obvious LPR as a consequence of advanced GERD and bipositional regurgitation. These are the more straightforward people. And the decision to perform anti-reflux surgery is often based on only a positive impedance test. So we've become very, very meticulous about our informed consent, talking about these patients, but a lot of them are at the end of their rope, and they want you to do something. So we just try and do the best that we can for these patients. And we need uniform testing criteria so we can compare apples to apples. So American Foregut Society and mentorship. This is going to be, I think, a really important thing. Lee Swanstrom was my mentor, and I was lucky enough to have him as my surgery dad, And so if you look at these quotes here, my mentor said, "Let's go do it, not you go do it." How powerful when someone says, "Let's." And then Steven Spielberg says, "The delicate balance of mentoring someone is not creating them in your own image, but giving them the opportunity to create themselves." And I see one of the primary purposes, or one of the main purposes of AFS is really to provide a mentorship to our up-and-coming, because our up-and-coming are the ones that are going to be the ones that carry the torch when we're long gone. And that's part of the purpose of what we do. Thank you very much.